Okay, thank you. My name's Adam Mahoney. Just a very brief introduction to me. I've spent about nearly 20 years working in the Scottish Prison Service. 10 of those was latterly at HMP Cornton Vale, which of course is no more. But that was a very formative time for me, a very seminal time in terms of just working in Cornton Vale, and as soon as you walk through the door and you have a caseload, it is all about trauma. So just a caveat about what I'm going to talk about. I do lapse into prisons and trauma a lot, so please take it from that perspective. A colleague of mine was looking at my slides and saying, there is the community as well, and absolutely right. For my sins, I work a lot in prison service and have continued to do so since leaving and joining academia, and I do a lot of work for the English prison service as well. But what I'm talking about today is, I guess, loosely defined as mental health issues or mental health disorders. Up there is, of course, a whole range of mental health issues and problems and difficulties that we're all dealing with in prisons. Foremost of those will, of course, be substance misuse, personality disorders, but also, and I really haven't had much experience about this recently, I'm supervising some Psychologist down in Liverpool at the moment, in the prison down there, and we have an elderly gentleman. We thought he had dementia. He's in a segregation unit, spitting and being very violent towards people, and we thought dementia was the issue. It turned out not to be. I don't assess for dementia, but the assessment that came back said no, but it's certainly an issue that we need to be thinking about as our prison service and the population within it gets, of course, older. But yes, I mean, a lot of the issues I will talk about today will be, very briefly today, will be about interpersonal trauma. That for me screams out to be one of the big issues that we're having to deal with and respond to. There's a little quote there, of course, and it says that 90% of prisoners have a mental 90% of prisoners have a mental disorder. I'm going to talk a bit about the prevalence, and I've reviewed the prevalence data again, and I keep on reviewing it and going back to it, and that will be, I think, a thing for us to think about in terms of what we know and, of course, what we don't know as well. So I'm like Lindsay, I'm talking about non-psychotic illness, and just to get it into perspective, these are the issues that will not cause anybody to be necessarily sent to hospital. In fact, they won't be sent to hospital, they'll be sent to prison, and we are dealing with those issues on a day-to-day basis. And we are often struggling to really think about what it is that somebody's got in terms of a diagnostic sort of paradigm or set of procedures that we might want to be treating and thinking about. And I think one of the really important issues for us to think about is the so what part. I mean, I'm not talking about so what in terms of we shouldn't be alleviating distress. I think that's a really important thing to be doing. But from a forensic perspective, from a criminal justice perspective, how does that feed into somebody's likelihood to commit an offence or indeed their behaviour in general? For me, I think this is a really big issue and one that we haven't often thought about in its entirety, and we have thought about in terms of criminogenic needs and how that might be important. And of course, we look at the issues in terms of, does that lead somebody to be more or less likely to commit an offence, and where should we put our efforts into in addressing those? And we certainly know that women and people in remand will have a higher rate of mental health problems. And that's, I'll go through some of the stats very quickly as well. But one of the things I really want to sort of just raise throughout all of this is that a lot of mental health disorders go unrecognised or unspecified or untreated. And indeed, we'll go on to talk about it, but is that an optimal way in terms of diagnosing and defining, and should we just be looking at the stress as well? Okay, so there were a couple of pictures there. There's a study in 2002 done by our friends in Edinburgh University looking at prevalence, and I will talk about that, and there's also some recent data in the English prison service. The recent English prison services, and I'm talking about this in its entirety because I work between both countries, but I think it's also important to look at what's the most up-to-date literature in terms of prevalence. And if we understand prevalence, I think we understand the need and the pressing need and what we can do about it. It's really important to understand, I think, the lack of knowledge about what is prevalent within, in terms of mental health within prisons at the moment. So Durkheim, which is, he's utilised the NHS caseloads, which consists only of about 14% of people in the English prison service being on those caseloads, has quite rightly said that he's had to go back for the most up-to-date or comprehensive information on prevalence, mental health prevalence, to data that goes back to 1997. Okay, that's quite, when I was sort of looking at this, I was quite astounded by that as well. And from that, he was talking about personality disorder being about 66%, drug use 45%, and alcohol dependency about 30% of the entire prison population down in England. Again, the study that that was done in Scotland most recently looked at doing a rapid evidence assessment and drawing out some of the prevalence data there, and they also came up with a whole bunch of issues and data that was relevant there. And the most important thing to think about, I think, and they highlighted very clearly, is that perhaps the most comprehensive data that was collected was in 2007 in terms of assessing the mental health needs in Scotland. I went back and had a look at that. It's not very comprehensive as well, and so we need to really be thinking about what we don't know in terms of prevalence as well. And in that, there was absolutely no mention of PTSD, which of course, as all of you know, is a really important issue for us to be thinking about. And I think one mention of trauma, so yeah. Just going back into other prevalence data that's out there, and this is really just to try and map out the issues and the needs from the population that we're working with. We can see that that there are different stats that are coming about, and if we look at personality disorder, anxiety, all the affect disorders as well, mood disorder, PTSD, we can see that there are some very big differences between the male and female prison populations as well. So these are, as we know, very key data that's out there that suggests that it's a very high pressing need and demand. But as I said, the prevalence data really needs to be thought about and updated a lot. Emma Facer-Irwin is a study that was recently completed using the International Classification of Disease, and the International Trauma Questionnaire is talked about a lot as being one of the most important sort of, or relatively important pieces of peer-reviewed research that map out the need as well. So from that new tool, and don't forget, I suppose, well, if you're not aware, that the complex PTSD was only relatively recognized as a disorder through the ICD-11 in about 2013. So before that, there was a lot of work that was being done in terms of saying, yes, we think it's a big issue in terms of all the trauma and the adverse circumstances that people are coming from, but we need to sort of really have this as a diagnostic criteria. I was speaking to Emma recently, and I said, well, that seems to be quite a low number, 16.7%. And she said, yes, absolutely. If we look at people who meet the threshold and people who meet the sub-threshold, you would have a lot of people who would be diagnosed or be recognized as having important issues associated with their distress and their functioning. Okay. So going back to the study that was conducted by our friends at Edinburgh University, including Lindsay and others, they did a logistic regression, very important piece of work, I think, to really try and estimate what the prevalence rate is, and they've come up with a few categories that I think we can all sort of recognize and think about in terms of long-term mental health conditions, histories of self-harm, alcohol use and anxiety, and we all know that they are substantially more prevalent, of course, in the prison service than elsewhere. We did some research when I was at Cornwall Vale with Thanos Karatsias, who's a professor at Napier, and we looked at 91% of people in Cornwall Vale having a history of adult and childhood trauma, 58% reaching the DSM-5, the Diagnostic Statistical Manual, of recognizing that they would have something that would meet the criteria for being diagnostic for PTSD. Along with that, we looked at self-harm and the rates of self-harm and how that was prevalent, and the different pathways that people might be going from their trauma into self-harm, and that sort of dual harm as well in terms of harming themselves and harming other people. So there's some really clear evidence there as well. I'm just going to briefly through all these slides, but this is some data. I was commissioned by the Ministry of Justice down in England to have a look at the self-harm rates down in England for the women's estate. And I recently had a look at it. It goes up until 2021 because they were very concerned about the increase in self-harm in their estate. It has, since then, I've just been reading, increased another 52%, and it's nearly off that chart as well. So self-harm and the distress and all of those things that are the sequel of trauma and adverse life experiences and repeated trauma are a very important issue that we have to deal with and address. This is another slide. I don't like the word prolific self-harmers, but that's a term they use in England for when you have 5 or more self-harm episodes in a month. And they were looking at essentially the people who were contributing most of their stats in terms of self-harm and what could be done about that. Now, obviously, this is a period over near sort of around about the COVID time, so we can think about that as well. But place of safety orders, when I think the sentencing difficulties of dealing with people who are very chaotic and knowing exactly how to respond to, particularly women, obviously women in this case, was very challenging and tricky. So there are a small cohort of individuals who are extremely distressed, self-harming, including mutilation, ingestion, and all sorts of things that really need to be responded to most appropriately as well. We have since put into place an intervention in the women's estate that tries to do that type of work with some of the most vulnerable and difficult to work with women. But it's very small numbers, and I think that that's an issue in itself. So just briefly, we kind of talked about prevalence and talked about the response. I've put up a whole bunch of things up there that I think are relevant. Talking therapies, obviously, as a psychologist, that's our thing, and we will say to do, and talking therapies is the most prevalent. But there's also really important joined-up thinking to be thought about in terms of mental health screening through reception, and how that goes all the way into the through care. I put up an environment there. The environment of a prison is so important. I've worked with some wonderful governors in my time who really take that on board and really seek to make the most enriching environment that they can. All of those staffing issues are so important. But it's the environment that people go back out to as well that I think needs to be thought about. So many times we've done some wonderful work only for people to be released into the community back to very difficult and challenging circumstances. Gender responsive, trauma responsive, those are all important things to be thinking about. And the things that I find quite frustrating working in Scotland sometimes is the lack of options that I have, particularly when I'm doing some of the assessment work for and it might be, where do I put this very challenging individual? What responses do I recommend they do? In England, we've got those therapeutic communities. There's the planned, the psychologically, get the pipes right, psychologically informed planned environments. I'm pretty sure that's the right way around for the P's. But there are thoughts about how can we respond to people with personality disorders in the most appropriate way. I'd love to see some of that in Scotland. I don't know why it's not here. But there are thoughts about that. I'll talk briefly about some of these things as well. Now, having worked for the Scottish Prison Service for many years, it's fantastic to see, as there is in all the Scottish Government literature, increased awareness of trauma-informed environments. However, it's really important we don't just leave it as a buzzword. That is the diagnostic criteria for the ICD-11. Disturbances in self-organisation and how we respond to those effectively is just so crucial and so important. And thinking about the effortful avoidance that people are engaged in, whether it's drugs, it's self-harm, whether it's just not thinking about it, whether it's other behavioural disturbances, so important if we're going to respond to that appropriately. So it's the complexity within that and the complexity within a forensic population I think we really need to nail and really need to understand. Okay, so I have data and stats coming out of my ears that I'm trying to publish. I've got probably a minute to go. We can make some changes. We can make some really effective changes when we have the right interventions in custody. The There's some data that I haven't yet published. I've tracked the cohort of 100 women who've been in Cornton Vale and where they're at now. Self-harm being a really important indicator, and that i.e. distress for where people come back. There's some data published in the Clinical Psychology and Psychotherapy Journal, looking at when we implemented a brief intervention called Survive and Thrive in the women's prison estate. And it's not always, when you do a proper experimental study with a randomized control study, you're not always going to get the data and the outcomes you recognize or would like. We didn't show a statistically significant difference, although if you have an adequate dose, you're more likely. So if you actually stick with the treatment. That very chaotic slide is just trying to say, look, people are on a different journey. So we have time 1, pre, post, and follow-up. We'd like everyone to go down, but people are on their recovery journeys that we need to support and recognize and wrap around. This is a newspaper cutting. I'm just going to briefly cruise towards the end of a woman that we worked with. Some of you recognize this case. I spent my life redacting and anonymizing data. This is a neonaticide case, and it took us over a year to get to an adequate formulation of understanding for this woman. And her sentence was reviewed from murder to culpable homicide. And just the length of time it really takes to understand somebody's needs, and how she presented, of course, at the time of trial, was one that was probably characterized by a lot of disassociation, and we really didn't understand the background, I think, that she'd been through and the amount of trauma that she'd been through. Okay, list of resources and references. I'm more than happy to talk about and provide those resources if you'd like to and want to follow it up afterwards. Just to say that we have data that is suggesting that we do well, but it's certainly by no means there as a rigorous scientific body of work to really say that all of these things work, randomized control trials, et cetera, but there's some good evidence out there that we can start to make a difference if we have the right interventions and the right things within an prison environment to respond to what is an overwhelming set of needs. Some key messages, but we need to be doing what we're doing better and differently. We need to know about the prevalence. We need to know about how we really address big systemic issues within our society, about poverty and social disadvantage, if I think we're going to make a big, lasting difference. But I shall leave it there and move on to the next speaker. Thank you.
Thank you very much.